Got it. All right, so we look into access to pediatric neurology training because we knew that. We said, what is the cause of this scarcity of child neurologists? So we look at access to training programs. And you can see here in red, this is where training program is available. And in blue, this is access to child neurologists. And look at that here. About 85% of high-income countries, 85% have child neurology training programs like yours. And of course, 100% of these countries have access to child neurologists. Now, bring your attention here, low-income countries, only 5%, and that's a super important data, probably the most important slide I'm going to present to you to make you think how important collaboration is. So 5% of low-income countries around the globe have child neurology training. And of course, there is a, scarcity of child neurologists. That's why, many countries in Africa don't have, cannot train people there, cannot train people. And it's a cycle, because if you have just one child neurologist, we just came recently from a talk we were talking about Tanzania has one child neurologist for the whole country, one of the largest countries in Africa. How can that person train? It's very busy clinically also. But anyway, and it was working okay, but let me just do it here. And that's not my fault, guys. Now it's not working. I did something wrong. Let me see. Johnny, do you mind? I know you're the expert. Okay, got it. Thank you so much. And now let me go into a little more detail about this situation. This is the distribution of neurologists, adult, in urban and rural areas. And you can see that most countries have neurologists in the capital cities, here in green, and large urban centers, here in blue. But there is a scarcity of neurologists in rural areas, here in purple. 0% in low-income countries. 0% because maybe there is one or two, but the data wasn't enough to collect it. And say, is that important? Let me show you why is this important. We're talking about epilepsy here, but just to illustrate one disorder, but there are about 46 million, you probably know that, of patients with epilepsy globally. But 80% live in rural populations and low-income countries. See, 80%. And I show you the previous data. We have almost 0% because we couldn't collect data of neurologists, forget about epileptologists, in rural areas. So big problem. That's why the treatment gap, the latest data from the WHO, shows there's more than 75% unacceptable. 75%. Yes, truly unacceptable in low-income countries. That's how we live. It's a global picture. But now let me go with the positive note. Because, all right, we knew that. Yeah, you probably know that, but I wanted to give you more data. In the data we collected, to give you some explanation why we have these things. And it's important to do studies, even if we repeat this bad situation, because it's important to know the why we're in this situation, even if we think we know it. So now I'm going to talk about potential solutions to minimize these disparities and improve patient care. Nationally, first, I think we need to increase research, local research, about disparities in neurological and epilepsy care. We need to do that. But we have to analyze multiple variables, not just race and ethnicity. Actually, most studies have been based on race, and race is a very, very abstract term, very difficult to define. I can ask any of you, please define race. And I bet you're going to have trouble defining race, right? And it's more difficult to study race. So, but there are many factors, socioeconomic status, and many more I'm going to show you later. So we have to analyze how these variables interact between each other. They're not separate. And that's a problem we had in most of our studies. So we need to address biological and behavioral, meaning intrapersonal factors, to look into disparities that place people at risk for neurologic disease. However, what can lead to more sustainable change are interventions that affect the context that shapes and replicates neurologic disease. That's important, our context, our environment. We have been not looking at it. That's why you hear this term all the time, social determinants of health. These have led to the recognition that unhealthful behaviors are influenced by factors in the environment that are beyond our personal control. And I want to share with you this proposed framework to study disparities by the NINDS. It's a very nice article that I think is going to change many things. It took many years to write it. It came in 2023. And the proposed framework is going to look at many variables. So structural determinants of health inequities, meaning policies and practices based on skin color, religion, sexual orientation, etc., looking at the structure we have. Social factors, meaning your family, where you were born, social class, occupation, race, sex, etc. Intermediate are very important, meaning discrimination or even segregation by race, ethnicity, or sexual orientation. And probably you know that, but I'm going to say, until the 1960s, the American healthcare system was legally segregated by race and class. And you probably know that again, but it was legal and often customary for hospitals to deny care to African Americans or to place them in inferior, underfunded, and overcrowded facilities. It's customary. 1960s, that was a recent thing. So intrapersonal factors, meaning physical activity, smoking, diet, etc. And of course, biological factors, hypertension, diabetes, place people at risk for neurologic disorder, obesity. But all these factors, the intrapersonal and the environment, play a role together. They are together. You cannot disconnect them like we have been doing to study this disparity. And you know, for example, a typical example, the growing fast food industry in poor neighborhoods, all the time. They don't thrive in neighborhoods that have people with resources live. They don't. Anyway, so, and now I'm here, like I have been in other institutions, to tell you what is the role of academic institutions. You say, okay, we're listening to Jorge. Is that important? We're going to change something? Maybe, maybe not. So I think academic institutions like yours and mine have to play an important role. Developing collaborations between community, very important to have community programs, and large academic centers like yours. Developing training modules for PCPs in neurology. Sometimes we don't have time for that. Very busy, but very important. For families, educational sessions, patients and families, to educate them, even about nutrition and many things. We can use telehealth right now to support rural areas or community that have no access to our center. Can do that. And importantly, minimize the economic burden, because some families from far away may not come to our center. So we have to have even a program coordinator and think about how we can help that person to have access to us. Globally, this is my last part. Globally, we have to support primary care providers. Very important. We have not been doing that. PCPs. Now we're focusing in this area right now. Actually, we'll have a meeting soon, but if you can go there, I don't know if some of you are going to for IGNA, and we're going to talk about that, how we can support primary care providers, mainly in Africa. And it is important to give these providers the resources they need to take care of patients. And let me show you actually this graphic here. You can see here the access to neurological guidelines for a specific neurologic disorder. See that 80% of high-income countries have guidelines. I bet you have guidelines for status epilepticus, for treatment of whatever. You have a stroke, of course you have it, you name it, 80%. Only 23% of low-income countries, when they don't have neurologists, they don't have guidelines, you see? And that doesn't take long. We start to think, doesn't take, long to develop them. So we started with a project I want to share with you with the Ibero-American Academy of Child Neurology. So we started developing guidelines for a specific disorders, epilepsy, neuromuscular, you name it. And we publish these guidelines in Spanish every year. I just came back actually from Central America from El Salvador to try to implement a guideline in infantile spasms. You know, infantile spasms can be devastating if you don't treat on time. So they were not treated on time, and they were not using a standard therapy. So now it's so easy to have a protocol, a recipe for prednisolone that is so cheap in our country. But you have to implement that guide. They have to have that guideline available. So that can say many things. You don't need to be a neurologist to implement a guideline, all right? And that can be extrapolated to other places. So in Africa, we are thinking, can we do something similar in Africa? We are going to discuss that also in Cape Town. And this is important because you see here, this is the first African Child Neurology Association meeting that stated that the capacity to diagnose common neurologic disorders, and of course rare disorders, is lacking in Africa. They don't have people that are trained. And the burden of neurologic diseases on the continent is not even known. So guidelines are extremely important. Very easy intervention that we come together, we can help many countries in collaboration. You help like you don't have an idea. We just created a simple guideline. Good intervention can help a lot of kids. But now, because I'm talking globally, you can ask me, so what is our role, Jorge, of our academic institution? Can we do something? Yeah. You should actually probably promote international outreach educational programs with low-income countries. I think we have a responsibility to do so. Support local training in poor resource countries when possible. We have quite a few projects that I can talk to you, whoever is interested later. But we use telehealth right now between large academic centers and poor resource settings. And I think that academic institutions can partner with medical societies to create programs. I'm going just to show you, just to finish a few examples, just because there are many, but this is University of Texas, UT Austin, that supported programs in the Caribbean, you know, to have better access to EEG, education for schools, for epilepsy, and even epilepsy surgery. And you can say, wow, and they have achieved so many things that we can talk 3 hours about what they are doing. And you see, that was easy. No, it's not easy. You well know here that the Caribbean is a very complex political bloc, mainly English-speaking islands, but only 4 of the 15 have English-speaking, have neurology care. 4 of the 15, right? So you have to put them together. And 3 of the 15 have epilepsy-trained neurologists. So a lot to do. It's a beautiful place, as you can see here. But on top of that, it's hit every year by a natural disaster, and in the middle of the ocean. And you see, for example, this beautiful hospital in Barbuda here. This was after the hurricane here, Irma. So these academic institutions like UT Austin, helping them is a big support. And anyway, so in my own experience, Ohio State helped me with supporting workshops and training programs in Africa, mainly for EEG techs. We discovered that the EEG techs are not trained in Africa, and the quality of EEG is so poor that you see artifact. We were going there and we didn't see anything, and the doctors were reading that. And so we're working with a company that is helping us to build infrastructure. Also training doctors there locally to read EEGs with their patients. And this is not my project. I just want to share with you that big things may happen also. This is Ohio State, our university. ID, they have a multi-million grants with the NIH to bring people from Africa, Asia to Ohio State. They train them, and these people go back and they develop their own labs and infrastructure, and they collaborate on research that is important for their country. All right, and they train people then locally in their country. So which is very nice. And they are talking to us, they talk to us already. How can we replicate this in neurology? We haven't, we not as smart as our ID friends, I said, maybe, but we're trying to learn from them, right? And just a few final points. What about medical societies, right? So medical society, academic institutions can do something. I think medical societies also can be catalyzers. I'm going to give you a few examples. This is the pediatric epilepsy training, or PET. You get involved, it's a great thing. Led first by the British Pediatric Neurology Association. The program is called Train the Trainers. Pay attention to it. They go there to Africa, they train the few child neurologists, and these child neurologists train healthcare workers, and then the healthcare workers train other workers. They have more than 1,000. That's all data. Really have more than 2,000 right now. So little interventions, a few days to go there, but huge impact because you replicate what you do. Our Child Neurology Society supports programs also. This is an example program in Pakistan, in Lahore, training child neurologists. I mean, Pakistan, if you know Pakistan, is very underserved, right? In specific programs in India, because India has very, very sophisticated centers like Chandigarh. So Chandigarh help us also to train other people because they have. I had opportunity also to work on multi-society projects, and then we have more power. Then we could do things and training things in other countries, many countries. Societies can give money, right? We members pay money, right, for your membership. Raise your hand if you are a member of just one society, right? Raise your hand if you are a member of two societies. Raise your hand if you are a member of three societies. See how many? More than three societies. See, so we pay, right? Do you pay for your membership? Yeah. So we have the money. So we convinced the Child Neurology Society to use a little bit of money, and also IGNA to do that. And they created the seed grants of this society to support local research, mainly in Africa for traumatic brain injury. It's a real picture actually in Africa. And you see, we don't do that in Columbus. It's not allowed or arrested, but that happens in Africa. So you can imagine all the trauma. For TB, meningitis in India, a wonderful research that they are doing to minimize the impact of this. And that's important to give money because if you look around the world, only 12% of countries have a specific budget for neurological disorder, 12%. And that's 0% in Africa, 0%. I mean, no budget for other things. Of course, there is no budget for neurological disorder. They have no money. Important for you to understand, no money. And only 4% of low-income countries have money for neurological disorder, meaning government money. And in just my last part, I wanted to share with you a survey we passed to a Child Neurology Society. We had more than 200 responses. And the members that responded, you see that 50%, around 50% already had experience in a medical mission. And we asked them, what were you doing? And they were training medical personnel locally, which is very good. And you can see that half of the responders trained in a US medical school, half of them international medical school. So we're not just outside the US, they were very interested, even they trained in the US. And the important thing is that about 60% of them work in academic institutions. Again, an important role of academic institutions that we have not been doing in society. Right? We have not been collaborating, getting the force of the academic institutions. And most of the members that did or work in medical missions, they pay themselves. They use, let me see, because that pointer now I have to point to the wall. Okay, here it is. So they use personal funds to finance the mission. A few of them have university funds. I have university funds. And department funds also, I have some. So that they have. And now we can map where the things are going, and we are getting more organized in helping people that want to get organized. We divided our international committee at the CNS. I used to work for many years as a chair of the committee. I'm not anymore, but I'm with Latin America right now, just working in Latin America. But we divided by different regions. So if you want to help a specific regions, we know where to. We want to be more organized. And the best slide is this. We ask all the members, would you be interested to be contacted? Look at this, 96%. I was so happy. So I said, then we probably think the same. 96% answered yes. The problem is we don't know how, right? I can, do I get the phone? Do I call somebody? Do I go by email? You see, because societies are not organized. And not just private entities, as I showed you before, this neurotech, company, give us like $50,000 a year. Foundations, we work with the Child Neurology Foundation and local foundations in the country. This local foundation in El Salvador help us to develop epilepsy surgery programs created by a little girl. Now she's 16, but she was 7 when she was operated, came to the United States and figured out that 95% of the population in El Salvador couldn't afford what she had. So she helped us with money and give medication to other things. So amazing example. And in my last slide, I want to share with you actually what we presented at the American Epilepsy Society, proposing a common platform model where all societies come together, because we're members of many societies, but we don't know what the CNS is doing internationally. We don't know what the American Epilepsy Society is doing. So we come together to develop long-term, efficient, sustainable projects, of course, with help of academic institutions, local governments. We are involving local governments when we can, foundations, private companies, and most importantly, local leaders. The people working there on the ground, they know their needs and they know the availability of resources. And with that one, I finish, and I want to thank you for having me here. And I hope I leave a little thought on you that things can happen. And, sometimes we cannot do big changes, and we would never change probably the face of this earth, ancient times to today. We always have problems and needs and disparities and minorities, and that we are not going to change, but we can minimize this thing. The topic today was to minimize, not to solve. Thank you so much. No further questions. Yeah, please.
Highlighted the in your presentation, you highlighted the lack of resources, particularly in the fact that there's a limited amount of child neurologists in these countries, and also just in the United States in general. Has any of the societies, or as part of your solution to fixing some of the, or to minimizing some of these discrepancies and disparities, looked into alternative methods for training child neurologists? Currently, our system is based on acceptance out of medical school and in certain tracks for someone who's an outside pediatrician or someone who's a foreign pediatrician who's already been practicing for a while. Is there any look into alternative solutions for them to receive that training and go back to their countries?
Yeah, thank you. That's an excellent question. That's what we're going to have a full day discussion in Cape Town to look about that. So now, after this paper, now we know that they are not child neurologist training. Yep. We look into a few solutions. I tell you in 1 minute, the quick response, what we are doing. The Red Cross Hospital in South Africa, where the meeting, please go if you can, the IGNA meeting will be there. In South Africa, they created a fellowship and they got some funding, but they lost the funding. So they just can train, they used to train 2 child neurologists per year, which is, it takes like about $30,000, $40,000 per year, dollars. And they lost funding. So they are advocating towards societies to give them more funding to train them locally in Africa, and they go back. They identify these countries in red that have 0 child neurologists, and they train them. But you see, money is an issue. There is a lot of money, you see here. I mean, everywhere there is money, but we don't send that money to where it should go. Maybe because we don't know how to market these things, and it's very difficult for healthcare. But this is one model to create programs close to the countries that need it the most. The other initiative we are having right now, I just had a meeting 2 days ago, was to focus on the training centers, mainly in Latin America. We know Mexico is a big center, Argentina, but they still need resources. So we're trying to support them. And the third project we're doing is we develop a curriculum, international curriculum, took us 3 years to have a more standard training program. We don't want just to create a program that is not good. That's worse than having no program. So we have the curriculum, and we are trying to push as an international child neurology association to give diplomas and things like that, recognition to the programs that follow that standard curriculum. And the last thing that I wish we could accomplish is we academic institution can collaborate with one center, one country, for example, or bringing doctors from overseas, for example, to train with us when we came. We have a program also in Ohio State, in a nationwide children's, called Steckler Fellowship. We pay that doctor for 3 months. We have $10,000 per doctor. So we train quite a few, mainly from Africa and things. It's not a lot, it's 3 months, but we give them a little topping and things like that. So, yeah, Dr. Giri.
In countries and specifically addressing India, we may not have that many specialized child neurology, and that's changing, but we have excellent pediatricians. And I think our emphasis should be in, helping these pediatricians go through 3 months of basic approach to neurology, because they all know and how to set up a developmental center, how to manage basic conditions like epilepsy. I think that should be one of our main targets, because we do have, people who take care of children.
Agree, Dr. Giri, agree. Yep. Actually, we are developing a professorship program. We don't know, the idea just started, that everybody who retires, and we're taking a list that has been a professor in an academic center, we're getting some funding, and to see if that person can go, let's say 1 month in Africa. We are starting in some places, and we have some housing. This has been also led by Boston and other places. They say you retire or somebody retired, you have more time now, and you can help us to it's funding only for traveling and housing.
I think that was both their points.
Thank you.
Well, there's one other thing that happens in big cities that is in addition to this. One of the other disparities that Steve Roach and I wrote about is these large medical centers, mostly in Manhattan and New York, and we talked about it in Austin too, that they sort of try to take the patients that bring in money and leave the others. So there's less care for autism, for example, in the outer boroughs, because they don't take care of those patients. They'll take cardiac surgery, they'll take epilepsy surgery, they'll take those. Again, that's mostly economic disparities. And then we have all the patients with CP that require a lot of care, and autism are sort of left in with the other hospitals. And that's also a discrepancy because of the competition between the medical centers for, income. And that's a separate thing entirely, and can be studied and looked at as well, but it's separate from what you're talking about. But there are all these factors that cause discrepancies, and it's interesting and needs to be worked on, as you say.
You're correct.
I do have a question. So you were talking about rural areas, especially in low-income countries. So obviously pediatric neurologists and neurologists are rare, but also local doctors will be few and far in between too. Have the people that you've trained or in some of these countries kind of have ways of maybe reaching either like local healers or a way of kind of getting more care out to those people that are in communities that are even harder to access?
Yeah, very good question. And mainly in local healers are in quite a few places. We just presented a poster about that recently. Another study we were doing, just the impact of local healers in how many people access. You would be amazed, mainly in Africa, but also Latin America, you see. But Africa, you have most of the people have better access to local healers. So, and that has been that's a work in progress, that if it should be communication between local healers and neurologists also for neurological disorders, of course. It's very important because they don't have access, right, to child neurologists. It's easier to access. There's a local healer, I don't remember by the ratio of local healers, but you have access very easily to local healers. It's in the culture, right? You don't have to go to a big center. The access is easier. So and probably we should be working with them. Something is part of the culture.
Hi, can you hear me?
We can hear you.
Oh, great. Hi, thank you so much for the inspiring talk. I'm an adult neurologist, and over the past few years, I've been working on a global neurology program for our trainees. And I've had several child neurology residents approach me and ask about opportunities for international electives, for global health electives. What advice would you, so I'm more familiar with the adult neurology territory and opportunities there. What advice would you have for the child neurology residents in terms of where can they search? What is the best place to start where they can search for these opportunities?
Yeah, thank you so much. That's a great question. That's my favorite question because I have to be honest, with the Child Neurology Society, we started lobbying for a website that is easier to navigate, and we are building it for first time, but it took many years. But right now, through the International Committee of the Child Neurology Society, it is in the website, and it is easier to get involved now than before for child neurologists. If you have any question or something, I know you can shoot me an email. You know, many here have my email, my contact information. I can guide you through the website. Yeah.
Excellent. Thank you.
Sure.
Hello. Yes, okay. Thank you for a wonderful talk. Great to see you. My question is about trust issues, essentially, and it's something that certainly Arthur Grant and his group have looked at with regards to epilepsy surgery, and how big a barrier is that? It certainly is a big barrier here for. Even when you do have an academic center with the ability to get patients to epilepsy surgery, it seems to take much longer. It does take longer to build the trust and to have the patients and their families agree to a treatment that in, say, Manhattan would be much faster. So how big a problem is that around the world? And then any strategies to mitigate that?
Yeah, that's 1 billion question. No, not me, but one of my colleagues wanted to address that. Even in Columbus, we have that issue also, and all depends on what population you look. Again, the studies may center just in one population. Again, most studies are looking at race. This is going to be something from the past in the new studies, but historically there are some populations that have been that do not trust the medical system because the medical system did things to them that should not have been done in the past, and that cannot be erased. They know that is in their history, and how we can come across this is difficult. In some places, they are trying to build clinics that with doctors that are part of the community, that are from the same race or speak the same language. For example, they are trying to do it in Austin, in Florida, Spanish-speaking clinic, to build more trust and to see if that in education, I believe education is important, but there is a limit to what we can do. And that trust probably has to be won very slowly. It's not something that is going to happen because it comes from generation to generation, the truth. But this is an attempt, and it's very difficult because you may not find so many doctors that Spanish speaking, not to say other language or Somalian, right? We have a big Somalian population. We don't have one Somalian doctor to help us to build trust. So that's very difficult. I don't know how to answer it, but those are some attempts.
Any last questions?
Yes, Brian and Jessica, not just to switch away from epilepsy for a minute, the high incidence of cerebrovascular and cardiovascular disease is very, Brooklyn is, somebody said it's the buckle of the stroke belt. There are social problems which have really nothing to do with direct medical care. For example, in Brooklyn, there are numerous fast food restaurants, the supermarkets, which are expensive, sell salads and vegetables, which are often rancid and old. And the population of, even of Crown Heights and East Flatbush has a much poorer chance of selection of eating out in good restaurants and supermarkets. And if the this really has to be handled by the city and the state. They should stop giving carte blanche authority for places like McDonald's and Burger King to build high calorie, high fat foods, which will eventually result in atherosclerosis and strokes, etc. And I think this has even happened in Africa, where there's been a movement of people to the big cities. Now, diseases like diabetes and hypertension were fairly rare among the rural populations, let's say, of Nigeria. Now that there's been a large movement to the cities, Lagos and other cities, there's been a big increase in the Western diseases. And I think one has to really look at the social factors, which are really not medical per se. North Manhattan study was, of course, done in Manhattan. There's not been a similar study done in Brooklyn, at least looking at strokes. So I think we really need to find out exactly what is going on, what the problems are, and deal with them if we really want to decrease at least atherosclerotic disease.
Hi, Dr. Nziska. It was a little bit hard to hear you, but I think I can summarize. You were saying that resources in Brooklyn are not necessarily less than those in Manhattan, but we need to really look at the social impacts of why people make the choices that they do, leading to health issues.
Yes.
Okay. Yes.
And I agree with Dr. Francisco about he was talking also about in the mother city, in the big cities, we were talking about the growing fast food industry and the choices. And we know that diet is one of the most important things that drives health also. So I agree with him.
Thank you all so much for your participation. You can always feel free to contact me if you want to reach out or if you need any information for Dr. Viadurre.
Thank you again. It has been a pleasure to be with you. Thank you.
Okay. Dr. Nziska, are you still there? I don't know if this is. I think he's still there, yeah.
Dr. Francisco, are you still there? No, I think he's gone. Yeah. So happy you were here. Bye-bye. No, he's not.
But he rarely replies, so usually that means he very much enjoyed your talk and showed up.
So I'm happy to Dr. Francisco, I just wanted to say hi, and it's a pleasure to be here. You have been my mentor. You cannot imagine how many of your teachings I keep in my brain, and I take it to Columbus, Ohio. I always say, as Dr. Francisco used to say, and they know you in Columbus, Ohio, Ohio State, Dr. Francisco. I would never forget the rounds with you, what you taught me. Thank you for everything. Wow. It's an honor to be here with you, an honor.
Yeah, I can't unmute. You're muted, Dr. Nziska. It's okay. I'm sure he heard. All right. Let me end the meeting.